Good morning. Thank you for allowing me to talk to you this morning about invasive lobular breast cancer. This is a less common type of breast cancer that we've started to learn a lot more about over the last several years. And today I'm going to be talking to you about lobular cancer in this setting of metastatic disease. What I'd like to do is start by defining lobular cancer, talking a little bit about its pathology and molecular features, as well as what we know about patient outcome with lobular cancer. I'll go on to talk about our current treatment standards and review some ongoing clinical trials with you, and then talk about some important research questions we have for patients with lobular for patients with lobular cancer. And finally, I'll end by talking about two hypothetical patient cases that highlight some of the challenges that we face clinically and some of the options we have for treating metastatic lobular cancer. So ILC, or invasive lobular cancer, represents 10% of all breast cancer. So it's less common than its more common counterpart, which is IDC, or invasive ductal cancer. ILC tumor cells are characterized by what we call a discohesive growth pattern. In other words, the tumor cells infiltrate tissue in a single file manner. And that is due to the hallmark of lobular cancer, which is loss of E-cadherin, which is a cell-cell adhesion molecule that makes the tumor cells stick together. And because of this hallmark feature, it can be more difficult to see on imaging, including on a mammogram, which can lead to, at times, a later stage of diagnosis for the patient. There also can, for instance, be an increased risk of multifocality on a mammogram, meaning that the tumor cells have infiltrated different quadrants of the breast. And in patients with metastatic disease, we can sometimes see spread to unusual sites where other breast cancers do not often spread to, such as the gastrointestinal tract, the ovaries, or the peritoneum. In terms of how common ILC is, we have seen an increase in incidence of ILC compared to IDC, and this is not really well understood. Like I said, although it represents only 10% of all breast cancer, it still affects a large number of patients. So if we ranked ILC as an independent cancer in women, it amounts to about 30,000 new cases a year. So that would make it the 6th most common cancer in women, making it more common than non-Hodgkin's lymphoma or melanoma. So this is an important disease to study. It affects a lot of patients, and despite that, it's been chronically understudied as a breast cancer subtype, and more research is needed. We've learned a little bit about some of the molecular characteristics of ILC over the last several years. Like I said, the hallmark molecular finding is that loss of E-cadherin that happens via abnormalities in the CDH1 gene, which is often mutated, or there can be other changes in the gene that lead to loss of E-cadherin. Most ILC is estrogen receptor positive, almost all of it. And molecularly, the subtype that we see the most often when we sequence ILC is the luminal A breast cancer subtype. We've seen increased rates of alterations in the PI3 kinase pathway, increased changes in ESR1, which is the estrogen receptor, as well as ERBB2 gene abnormalities. Sometimes you can see increased rates of HER2 and HER3 abnormalities in lobular tumors, as well as abnormalities in FGFR, especially in metastatic samples. In terms of patient outcome, there have been some studies looking at outcome of patients according to their histology, meaning long-term follow-up of patients with early breast cancer, and looking at how they fared in terms of relapse rates according to whether they had either ILC or IDC. And we see a different pattern emerging where in early follow-up for the first 5 years after a diagnosis of early stage breast cancer, we see a slight elevation in recurrence rates in IDC compared to ILC. But with further long-term follow-up, the pattern flips and we see an increase in late recurrence rates for patients with ILC compared to IDC. And that is another important research question to understand why we're seeing this and what makes lobular breast cancers slightly more likely to recur later. Moreover, in 2012, we saw some data presented on the Big 198 study about potential for differential response to hormonal therapies for patients with lobular cancer compared to patients with ductal cancer. So in that analysis, they went back and retrospectively looked at a trial in postmenopausal patients who were treated with either an aromatase inhibitor or tamoxifen after their diagnosis of early stage breast cancer. We know that many such trials were performed back in the day, and overall, we know that there is a slight advantage to aromatase inhibitors over tamoxifen for women with postmenopausal breast cancer. But what was interesting about this particular analysis is when they looked at patient outcome according to histology, for whatever reason, the patients with ILC appeared to have an even higher proportional advantage if they had been randomized to the aromatase inhibitor arm compared to tamoxifen. So that was, again, sort of an unplanned looking backwards of patient outcome according to histology, but it was definitely generating interest about the question of, is there a difference in how patients with lobular cancer respond to hormonal therapies? And if so, that would be really important for us to know when taking care of these patients. We need to understand if there is a difference, why, and how we could potentially learn from that difference when we're tailoring hormonal therapies for the future. The finding of that analysis also mirrored some of the preclinical studies that we've seen in the laboratory. My collaborator, Dr. Steffi Oestreich, when I was at the University of Pittsburgh, has generated a lot of data preclinically in the lab using breast cancer cell lines. And we have seen with that data that when you treat breast cancer cell lines with commonly used hormonal therapies, we've seen some slight differences as well in how the lobular breast cancer cell lines respond to hormonal therapies compared to the ductal cancer cell lines. And what we saw was when you treat both cell lines with tamoxifen, tamoxifen inhibits the growth of the tumor cell lines. But in the lobular breast cancer cell line, the tamoxifen did not fully inhibit growth back to baseline the way it did in the ductal cells. And in the absence of estrogen as a ligand, we saw that tamoxifen actually served as a partial agonist or stimulus of growth in the lobular breast cancer cell lines. So when we were looking at that data in the context of the previous Big 198 analysis that I described to you, that generated a lot of questions for us about the importance of studying differential response to hormonal therapies in lobular cancer. And what we know right now is that there are no treatments that are specific to lobular cancer. Right now, we treat patients with lobular breast cancer in the same manner as we treat their counterparts with ductal cancer that is estrogen receptor positive. There are no ILC specific treatments. And so we started asking ourselves, should there be? And if so, how could we help study and learn to develop some? So this really emphasizes the importance of research for patients with lobular cancer. And I'm going to show you some of the ongoing trials right now that are accruing patients with lobular breast cancer. So there are two studies going on in the preoperative setting for patients with newly diagnosed ILC, and that is the TBCRC 037 study, as well as the PLOP study. And then there are two studies going on for patients with metastatic ILC, the Rollo and Gelato trials. So I'll start by talking about TBCRC 037. So this is a trial that we developed and planned. We started working on this back in about 2013, I believe, when I was still at the University of Pittsburgh. And we, as I said, developed this study with the specific aim of asking whether there's differential response to hormonal therapy in lobular cancer. So the trial is a preoperative, what we call window study for women with postmenopausal breast cancer that is ILC. And after they are enrolled on the trial, they are randomized to either tamoxifen, anastrozole, which is an aromatase inhibitor, or fulvestrant while they wait for their planned surgery. They take the drugs for 21 days while they wait for their planned surgery. And the entire point of the trial is to compare tumor tissue before and after exposure to these commonly used breast cancer drugs. It's a collaborative effort across several institutions through the TBCRC, which is the Translational Breast Cancer Research Consortium. And we know that all three study medications are common breast cancer treatment, but we are really aiming to study response and resistance to these treatments in the tumor tissue. So we'll be planning full sequencing of these samples and pathology studies before and after exposure to the medications. And we're hopeful that the data that we generate from this trial will inform future treatment of lobular breast cancer. It's been a very collaborative effort across multiple sites. It was started at Pittsburgh, but it has involved MD Anderson, Mayo, University of Washington, University of Alabama, Montefiore in New York, University of North Carolina, UCSF, University of Chicago, Baylor, and we will soon be opening it here at Penn and hopefully also at Georgetown and Duke. So this is just telling you how many sites it takes to do a trial for lobular breast cancer. And we're very excited to say that we have about 115 out of 150 planned patients so far enrolled on the trial. We also know that there is the PLOP study ongoing. This is led by the Dana-Farber group, and this is a sort of similar design in that they're looking at preoperative hormonal therapy in a window phase, and during that phase of the study, they're looking at letrozole versus tamoxifen for patients with ILC and IDC. So this trial includes both patients with ILC and IDC. And the second phase of the study is going to look at response to these hormonal therapies with or without palbociclib. But the first phase, the window phase, is looking at a similar endpoint, proliferative change in the tumor, whether they're on the tamoxifen or the letrozole, and whether they have ILC or IDC. So we very much look forward to the data from that ongoing study that also includes a number of different sites. So that is also a good example of collaboration across institutions to study ILC. Next, in terms of trials for patients with metastatic ILC, we have the ongoing Rollo and Gelato trials. The Rollo trial is run via the Royal Marsden Study Group in the United Kingdom, and this is a phase 2 study for patients with metastatic ILC looking at a drug called crizotinib, and the drug is being given to patients on the study who have lobular breast cancer or diffuse gastric cancer. It's a single-arm phase 2 study, and in the breast cancer patients, they receive crizotinib and in combination with fulvestrant. And the reason that they are looking at crizotinib in combination with fulvestrant is that crizotinib is a small molecule inhibitor of ALK and ROS1, and it basically is licensed for lung cancer. But when cancer cells are defective in CDH1, such as lobular breast cancer cells are almost universally defective in CDH1, they cannot survive when the ROS1 protein is defective or missing. So when they looked at laboratory cells, crizotinib inactivated ROS1 and therefore killed these E-cadherin defective cells. And they've also looked at this in mouse models and seen some efficacy there. So we very much look forward to data from that trial exciting ongoing work in the metastatic setting. Next, the gelato study is looking at a combination of carboplatin, which is a commonly used chemotherapy drug, in combination with a drug called atezolizumab, which is actually an immunotherapy drug. And the reason that they are using this combination for patients with metastatic ILC is that there are a subset of ILC tumors that express what we call immune cell markers, and then also have an increased infiltrate in the tumor of immune cells. So the question that this trial is looking at is, will there be responsiveness to therapies that target the immune system, such as atezolizumab, in a subset of lobular cancer, especially in that subset that has these immune cells in their tumor. And so those are the ongoing studies, and we definitely need more, but at least that's a start. We have to keep in mind that it's only recently that we've sort of even recognized these unique features of ILC, but there is definitely more work to be done. The next thing I'm going to talk about is a couple case examples, like I said. And the first case I want to present to you is a 41-year-old woman who was diagnosed with a 2-centimeter left-sided breast cancer on mammography, and the ultrasound confirmed about a 2-centimeter mass, but then noted some lymph nodes in the armpit. So the biopsy showed ILC that was estrogen receptor positive, as is commonly the case, and HER2 negative. When she got her breast MRI, as is commonly the case with lobular cancer, there was more widespread involvement of the cancer in the breast that was seen on the standard imaging, as well as more lymph nodes. So that made, at that point, a diagnosis of stage 3 disease. However, the patient then complains of abdominal pain and fullness. So she got some full body scans with a CAT scan, a transvaginal ultrasound, and a bone scan, all of which appeared unremarkable. She also complained of some low back pain. Shortly thereafter, though, she noticed some skin lesions on her chest wall, neck, and abdomen, and the biopsy confirmed metastatic lobular cancer to the skin. So at that point, that does confirm metastatic disease, and in that setting, it is standard to make somebody menopausal. That is one of the goals of treatment, and she chose to do that via removal of her ovaries. And when those ovaries were removed, they showed metastatic ILC in the ovaries, which is actually a site that is more it's a bit of a unique pattern of spread to the ovaries, like I said in the beginning of the talk, that is seen with ILC. It's not that it can't be seen with IDC, but it's much less common. Because of her back pain, she also got an MRI of her spine, which showed really nonspecific findings. We call them sclerotic changes, or small little scarred changes in the bones of her vertebral bodies in her spine and her hip bone, but it wasn't really diagnostic for bony metastases. And she did have a disc bulge at L4, L5, which could have very well explained her back pain. There was an attempt made to biopsy the L1 vertebral body, but it came back negative for cancer. So she was started on a common treatment for metastatic breast cancer with a combination of an aromatase inhibitor, letrozole, and palbociclib, which is a CDK4/6 inhibitor, also known as Ibrance. You may more commonly know the names of those drugs by their trade names, which would be Femara and Ibrance. So in summary, this patient was diagnosed with de novo metastatic cancer, which means she had metastatic disease at the time of her original presentation with cancer to the ovaries, to the skin, and possibly to her bone. So the questions that this case generates are multiple, but I wanted to go through some of them sequentially, such as which patients do need whole body scans at the time of their initial diagnosis. In this particular case, we did not see much on her CAT scans, on her bone scans, so would a PET CT have helped? What was important for the doctor to listen to about her initial presentation that led to the scans? So in terms of who needs staging at the time of their original breast cancer diagnosis, we know that ILC and IDC can go to sites such as lymph nodes, bone, liver, and lung. The ILC can go to, like I said, slightly more unusual sites such as the peritoneum, the gastrointestinal tract, and the genitourinary tract like the ovaries. And these sites can be more difficult to see on pictures. That being said, many women with both IDC and ILC and early stage breast cancer will never develop metastatic disease, and especially if they have very early stage disease. So it is definitely not universal to get full body scans on everybody, and current guidelines recommend that you don't actually. And current guidelines also recommend that if you do have a recurrent situation that you start with standard imaging studies, but we know that PET-CT is sometimes useful in situations where standard studies are either equivocal or suspicious, but not quite diagnostic. So I wanted to talk about one study done by Dr. Ulaner and colleagues in 2015, just to highlight why we don't do these scans in everybody at the time of their original diagnosis. But in this particular study, they looked at 146 patients who had been diagnosed with lobular cancer and got a PET-CT scan of their whole body at the time of their diagnosis. So the PET-CT only showed distant metastasis in about 8% of the patients with lobular cancer. And when you looked at who they were, there were 0 patients with stage 1 who had metastatic disease. There were about 4% of patients with stage 2 that had metastatic disease. And by comparison, when you got up to patients who had stage 3 breast cancer, like the patient I presented, there was an 11% rate of finding distant metastatic disease with the PET-CT scan. So it really seems like stage 3 is where the scanning process, if you will, became more warranted. By comparison, though, when they looked at a matched cohort of patients with invasive ductal cancer with stage 3 disease who got the PET-CT scan, it showed distant mets in 25%. So the percentage was higher. So I just wanted to show that data to emphasize again that the risk of metastasis was low in the patients with very early stage disease. But what was important to think about in our patient that I presented, our hypothetical patient, was that she did have stage 3 cancer and she had complaints. And so both of those findings warranted the state of the studies in her case. So the questions for her now is how do we follow her now, knowing that her original imaging did not really detect her metastatic disease in her ovaries, and we don't even really know whether the findings in her bones are cancer or not. And so my answer to that would be, in her case, I probably would try to get a PET-CT scan to see if any of those changes in the bones were bright on the PET-CT, or to see if anything else was bright on the PET-CT, because if it was at baseline, then we would know, okay, then this patient would probably benefit by following her treatment course with a PET-CT. If it's not bright on the PET-CT, then we know it's not going to be helpful. And that is a difficult situation, because then you have a situation where, she had disease there and you can't see it. So I think in a patient like that, it's really important to ask her how she's feeling as you start treatment. You can try to get tumor markers, but we know that about half of patients with metastatic disease won't even have elevation in their blood tumor markers. So some doctors do not find it helpful to follow tumor markers. I personally follow tumor markers in patients with metastatic disease if they do seem to track with the course of their disease. In terms of how long she remains on her current therapy, we are going to recommend that she remains on that therapy with the aromatase inhibitor and the palbociclib for as long as it works, as long as it's tolerable to her. In terms of anything else should be added to her medical therapy right now, and I've listed Zometa and denosumab as examples. So these are osteoporosis drugs that are extremely helpful at treating cancer in the bones. And they make the bones less likely to have bone breakdown and turnover, and that discourages further worsening of cancer in the bones and further spread to bones, and it really helps manage pain and symptoms. However, in her particular case, we're not sure she has cancer in the bones. So my answer, we attempted to biopsy it. The biopsy was negative. And so I might hold off on adding that yet until maybe we get the PET CT scan. If it's bright on the PET CT scan, I would start it. It's also important that patients see the dentist before you start osteoporosis medicines, because they can really rarely have a risk of something called osteonecrosis of the jaw or an infection in the jawbone. So it is important to get a dental evaluation, and if there are any major dental procedures that need to be done, they should be done before initiating those agents. And the most important goals of care for the patient are to make sure she has a good quality of life on the treatment, to talk to her about side effects of treatment and tolerability, and make sure that she is generally feeling well, because there is a chronicity to this treatment, you know, that we're going to keep it ongoing as long as it's effective, ideally. So it's really the beginning of potentially a long time for her, because we know that the average length of time that patients stay on their first treatment in this setting is about 2 years before you even have to switch to a different treatment. Now, the second case I'm going to present is slightly different. This is also a young patient, 50 years old, diagnosed 5 years ago with a stage 2 lobular breast cancer. At that time, she had bilateral mastectomies and started tamoxifen. And 3 years later, after that, she developed bone pain, and unfortunately, biopsy of a rib showed metastatic lobular cancer to the bone. So she started letrozole and palbociclib after getting her ovaries out. And she was on that for a relatively short time before she had, unfortunately, progression of her cancer. So this treatment was not effective for her. And the next treatment that was attempted was fulvestrant, which again only worked for 4 months until there was progression of disease in the liver. So the contrast about this case is that we're seeing a sequencing of progression on hormonal therapies in a relatively quick fashion. And so when you ask yourself, you know, what is next for this patient, this hypothetical patient, you say, well, you know, these hormonal therapies are not giving us the mileage that we're looking for. And in terms of what you would do today is so that patient was treated, remember, she was diagnosed 5 years ago, so she received fulvestrant alone. But nowadays, we also have consideration of use of alpelisib with fulvestrant. So she would have gotten testing on her tumor for something called a PIK3CA mutation. And if she had had that mutation in the tumor, then alpelisib would have been used with the fulvestrant and hopefully helped get a little more mileage out of the fulvestrant. Because she was diagnosed and treated before alpelisib came to market, she did not get that, but that would be important to consider today. So in terms of what's next for our patient, we would really want to make sure she had BRCA1 and 2 testing at some point, because it seems like that we are getting ready to start chemotherapy because the hormonal therapies are not working. It's not that you can't try hormonal therapies, but let's say that our patient, the disease in the liver has progressed at a slightly increased rate or an increased burden, and we really want to get a quicker response, then we would start thinking about chemotherapy. And we would want to make sure that it is an option to use a PARP inhibitor if patients have a BRCA mutation, so we would want to test for that. So in our patient, she tested negative for a BRCA mutation, and she started Xeloda, which is a chemotherapy drug. And she stayed on Xeloda for 8 months before she had further progression in her liver. And I think there's a lot of concern that patients with lobular cancer may not get as much benefit from chemotherapy based on several small studies that have been done showing lower rates of response to chemotherapy in the preoperative setting for lobular cancer, but it is compared to ductal cancer, but it is important to remember that we very much rely on chemotherapy for treatment of patients with lobular cancer when their hormonal therapies stop working. And so in this particular patient, the Xeloda did work for 8 months, and then unfortunately she again experienced progression in her liver. And now we have her on weekly adriamycin. And the reason we'll say we chose adriamycin in this case is that the patient did not have chemotherapy for her early stage breast cancer because she had a low risk oncotype, say. And in that setting, in a patient who has not had an anthracycline for their early stage disease or their prevention of spread chemotherapy because they didn't need chemotherapy, an anthracycline can be quite helpful in patients who have progressed on other chemotherapy agents such as Xeloda. Weekly adriamycin is fairly tolerable from a side effect profile, and it led to an immediate and significant improvement in her clinical symptoms with less bone pain, dropping tumor markers, and shrinkage of her liver lesions. And she's now been on it for 6 months. So what are her options for later line therapy? The problem with adriamycin or the anthracycline is that you cannot use it forever because there is a lifetime limit in terms of dosing, where if you go over the lifetime limit of exposure, it can increase someone's risk of congestive heart failure. So we're all aware of that limit and stay away from it. So say your patient gets to the point where she's been on the adriamycin and everything is extremely stable and she's had no further progression, but you have to stop it because of the lifetime limit. It might be an option at that point to circle back to hormonal therapy, especially if you're at a stable point. I would do that cautiously because generally you do try to exhaust hormonal therapy first before you transition to chemotherapy. But in this case, say we transitioned to chemotherapy at the point we did because of the size of her liver lesions and a desire to get a quicker response, it might be an option to try hormonal therapies that you haven't tried yet, such as everolimus and exemestane. So exemestane is another aromatase inhibitor, and everolimus is an mTOR inhibitor. We know that the PI3K mTOR pathway is aberrant in many lobular cancers and other hormone receptor positive breast cancers. So this might be an option here to try that, provided that there was no estrogen receptor mutation in the tumor, because that can confer resistance to aromatase inhibitors. Other options would be other single agent chemotherapies, such as eribulin or gemcitabine. And when you're choosing between these single agent chemotherapies, you're always thinking about side effects. You know, does the patient have neuropathy from chemotherapy before? You know, how are the blood counts? So you're choosing your agent at this point more based on side effects, because efficacy is going to be pretty similar once you've been exposed to several chemotherapy drugs. In rare circumstances, we can see changes in the cancer. This is not specific to lobular cancer, but you can see abnormalities that could potentially confer response to some other drugs, such as NTRK fusions or microsatellite instability. And these are listed in NCCN guidelines as options to test for and consider for use of drugs that target these abnormalities, but they would be extremely uncommon, but worth looking for. So in conclusion, ILC is a unique cancer in women when it comes to breast cancer. Some of the characteristics of the patients are different, the pathology is different, and we've now seen molecular characteristics that are different. We've seen an increase in incidence that has risen disproportionately to IDC incidence, and therefore there's really a critical need to understand response and resistance mechanisms to our current breast cancer hormonal therapies in order to develop better therapies for patients in the future. I've reviewed with you the ongoing trials in both the early stage and metastatic setting, and I'm very hopeful that they will inform biomarker identification and development of some true ILC specific tailored treatments in the future, but we definitely have a lot more work to do before we get there. I'd like to thank you for listening today. I'd also like to acknowledge Susan G. Komen for a Career Development Award that has been instrumental in the development of TBCRC 037, the clinical trial that I mentioned. We also have support from AstraZeneca for that trial. I'd like to acknowledge the Lobular Breast Cancer Alliance for all of their hard work at promoting the awareness of lobular cancer, the importance of research, and doing such a tremendous job of educating both doctors and patients about lobular cancer. I'd like to acknowledge my collaborators. I'm currently at the University of Pennsylvania, but I'd like to also acknowledge my collaborators in Pittsburgh, including Steffi Osterreich, who I mentioned, as well as Priscilla McAuliffe, who is currently leading the clinical trial after my departure. And there are so many others who have worked on the study of lobular cancer, but I'd finally like to end by acknowledging all of the patients who are dealing with this diagnosis and all of the patients that have already participated on the TBCRC 037 trial. And thank you for your attention today. And hopefully we'll be back to you with more updates soon once we finish the trial. Thank you.